distal bile duct because there are some stones in the duct. So this is where I give a little injection of contrast. And so Kiri's going to give a little bit under fluoro, a little bit of contrast. Go ahead. I'm looking for side branches. That's the first thing I'm looking for. If I get the bile duct, great, but I want to be sure I'm not in side branches. Keep injecting here. I don't see side branches. So it's a tortuous duct, and that's actually the bile duct. So there are multiple stones. But it's really important to understand, you don't want to advance the wire too much until you know fluoroscopically whether you're heading toward the bile duct. And the second thing is if you're going to use a touch of contrast, be sure that you're looking for side branches because you don't want to be in the PD injecting, even though that happens sometimes or a lot of times. So go ahead and advance the wire here. And so endoscopically, there we go. Okay, break the wire to me. Can we get the short CRE balloons? I'm not sure yet. You can grab like a 10 to 12 and 12 to 15 maybe. But you can see endoscopically, my opinion regarding the endoscopic position here, I'm going to inject a little more. And we did give antibiotics. And I don't routinely give antibiotics for, wait, why do we give antibiotics? Hold on a second. Why do we give it? Oh yeah, because she's immunocompromised, we gave antibiotics. But I don't routinely give antibiotics for stones unless we're planning to do cholangioscopy, injecting here. So there are multiple stones here, and Carrie's amused by my lack of decision making, which is good. And we're still injecting a little bit, just a touch more. And I'm going to
now we're a little bit more judicious with contrast.
stop here.
It's floating up the duct if you over inject from.
You're breaking up a little bit there.
Can you hear me?
Can you speak a little closer, maybe?
Yeah,
Am I coming through?
it's breaking up the audio.
I think the question that, can you hear me okay?
Yeah, we can
we
hear
can
Raj.
hear you,
okay.
Raj.
We have a speaker account, please. The question that Jeff was asking me was related to there we go. So we can send this image over to reference like this. Yeah. So the question is related to when are you more conscious about injection? Am I right? Yeah, judicious use of contrast. And I think that in the setting of cholangitis, we generally have been taught by the great grandfathers of ERCP that you've had the privilege to work with, Dr. Lehman, and I worked with Dr. Howe, and there are many others. But that they would recommend that once you get decannulation, you aspirate, do something to decompress the bile duct before you do too much injection. And I don't know if this is the question you were trying to get at, but that's one thing we do. And the other thing is that even if you do a little bit of contrast because the device doesn't aspirate really well, then we will do a sphincterotomy early on. And that sort of immediately decompresses the duct. You don't have to worry about the aspiration part.
Yep.
Meaning in the setting of cholangitis. And then of course with the PD, we try to limit the amount of contrast that we're injecting.
Yep.
So the cautery that I'm going to use is a 131 initially. This is an RMIE 2. And this is an autotone with a short straight jag revolution that we're using now. Okay, go ahead and bow up a little bit. That's good right there. And so can you see my hands by chance? Let's go to a view that shows my hands, please. Meaning not just that, but that maybe the quad image or something. And so what we're going to do, we still need the endo view
We can
too.
see you, but not your hand.
Raj, we can't see
You
your
see
hand. Can
us
you hold
and
on
the
just
endo
for a
and then the
second?
hand. You want to step back. Oh. Okay, if you go back to that view you were just at, I bet you'll see it. Yeah, but we wanted to see a quad image. So we want to see endo, fluoro.
Now we
And,
see your
yeah,
face.
like that. Very good. Kind of. That's all right. Well, should we be able to wait or?
It might
just
have been
cut?
the previous view, but just maybe
Zooming in on your
zooming
hands.
in on your hands.
There you
and-
go. That's
there, oh,
much
that'd be
better.
good.
Yep.
Oh, there we go.
Love
Okay.
it.
So I usually will unlock my dials. Others will lock the dial. Like my preference is unlocking the dial. And now does your in-room view have this sort of grainy thing from what happened there? Oh, does it have these lines in it? I'm just curious.
The one that's looking
lighting in the
down
room?
does, but the
What can we
one
do
that's
about the
looking to the
lighting? What do we
side is
turn the
okay.
light up? Turn the light up. Keep going. Well, it's still there. But that's okay. I can work in this kind of lighting. I'm sorry that you'll have to see a little bit more of me and Carrie, but actually me more. Carrie looks great. Yeah, sorry, I didn't mean to throw you in there too. Yeah. Okay, so the endoscopic, the hand movement is essentially unlocking the dials, and then I'm going to, the goal is to try to get that cutting wire just slightly or as perpendicular as you can to the upper fold and the common channel. And I'm going to use my left thumb. If you can, use the left thumb to both big wheel and small wheel. Do we have the endo view there? Can you
Yeah,
guys
we
see
have
the
the endo
endoscopic
view
view
and
too?
your hand view.
Okay, there we go. That's a lot of talking on my part. So, but I'm using my right hand to push the duodenoscope slightly. And of course, can't see now. Yeah, maybe we should get, well, it's okay. Do you know how much glucagon costs? Crazy. Well, 10 years ago, glucagon was about $350 here. So I don't know what it is now. All right, let's go. Let's go. We can go here. I think it's more an image. It's just a blurry image. Does that image look blurry to you?
Absolutely,
Yeah.
yes.
Yeah. Are you connected? You are. The grounding pad. Okay, we're gonna double check the grounding pad. It's green now. Okay. So
Raj, as
I
you're
don't know.
about
I
to
mean,
cut,
Yeah.
can you just tell us what your strategy is? Are you planning on doing a complete sphincterotomy or leave enough room for a large papillary balloon dilation? I'm sure you've thought of all of that with these many
That's a
stones
very
that
good
were
point.
identified.
Very good point. I'm glad you brought that up. I'm looking at the stones, and I'm sorry we didn't interpret the cholangiogram very well. But on this image, you can see the stones. The largest one is maybe 10 millimeter, 11 millimeter, possible. Are we able to reference this? Let's see. I think I can do this. Oh yeah, that's better. Do you see this image here on the fluoro?
Yep.
So I think the largest stone is probably 10 millimeters,
Yeah.
maybe at the most, and the duct is probably about 15 millimeters. So we'll do maybe a half partial sphincterotomy. We'll start at 131, and then we're going to use a 10 to 12 short CRE, unless you guys think differently. Now
No,
that was
I
more
like that
cautery
idea.
than I'd like to see. That's the reason I low to 131, but it might have been more an issue of pressure applied. Jeff, do you have a suggestion regarding that? Seems like a lot of cautery there.
Yeah, you could tense up the tomb a little bit more and maybe bring a
Go
little
up
bit
a
more,
little more?
yeah. Bring a little bit more out of the duct and just cut to the tip of the wire. Always try that. That gives you a little more of a, yep.
And Raj, even
Okay,
when
sure.
we
Get you
looked
lift
at
off
the
a little bit better.
stones, we looked at the stones on
Yeah.
EOS, none of them were greater than 10 millimeters.
Oh, I see. All right. So maybe we'll get a 10 to 12. Well, what would the panel do with respect to the strategy here for stone removal?
Yeah, I think if you're
Well, we don't
thinking
need that big a sphincterotomy.
large
We'll be all right.
papillary dilation, especially to facilitate multiple stones, then just a partial sphincterotomy, and then just divide and conquer with the extraction balloon starting distally.
And what do you, and what's your opinion about the, what a partial sphincterotomy, 50% of the transmural fold?
I guess it's a pretty subjective question, but
Does that sound reasonable?
yeah, I guess just enough room for the balloon to expand and hopefully not tear through the wall.
Okay. So if I use a 10 to 12, I would say this is about a 4 or 5 millimeter cut maybe. And then we're going to do the balloon dilation. Does that seem reasonable or should I cut more? What do you think, Paul?
Looks like there's a
Natalie?
lot of room there, even
I
with the
think you can cut
dilation.
more. I think you can cut
Cut
more. Raj.
more? All right. Why didn't you tell me earlier? I was already doing the exchange.
Yeah, no. I mean, I still think you need to cut more.
I still should cut more. All right, fine. Okay, so here we go up a little bit more.
And as everyone's voting for
And
cut more, tell me, are you looking at?
everybody
millimeters?
said
Are you
cut
looking
more,
at the
okay.
Features, are you looking at?
Which-
The
which-
give-
There's a lot of
Yeah, I
consensus
mean, I
there.
think
It's very,
just
I
more
almost feel
room at
bullied.
the end of the
All right.
bile duct is what we're looking for.
So hands are still here, big wheel is closer to me. And, you know, part of it may be the limit on nothing. Okay, let's go. What do we got? You know, could we just do a sphincterotomy alone and just take these stones out? Why balloon dilate?
Yeah, I mean, that's a
Right?
reasonable first step. Maybe the stones are small, maybe they'll come through the sphincterotomy. Yeah, that's possible.
All right, relax all the way. Yeah, but you know, I think I know that what you saw in EUS, but there could be one, you know, the one that I thought was 10 millimeter could be 2 stones and they might come through. Okay, but I would say that we see this commonly, and Jeff, I'd love your opinion of the panel of these patients that have chronic stone disease, which is what this is, and they get a fibrotic papilla.
Yeah.
And I'm wondering if some of that cautery effect wasn't just my suboptimal technique, but maybe it was partly related to the fibrosis in the papilla.
Yeah, I agree with that. Am I coming through, everybody?
Yeah.
Yes.
Can you hear me?
Yes.
Yeah, I think you will see that patients will have kind of just above the papilla, a little bit of fibrosis or even a short segment stricture that's inflammatory, and you have a lot of trouble getting to it with the sphincterotome and cutting through it. So I think that's maybe another advantage of the dilation as you break that up, and it speeds up the case, especially with multiple stones, because you can rapidly extract them and you don't have to spend time trying to work that balloon down through that fibrotic orifice. Also, if the patient also has a long intraduodenal segment,
Go ahead.
sometimes that dilation will open that up a little bit and help you deliver the stones a little bit easier. So, I mean, that would be one argument for it. But if you just go by stone size, you know, stones less than 10 millimeters, usually you don't need a DACE in order to deliver them. But, you know, those are some considerations, but be interested to hear what the panel thinks.
I did want to make a comment that what I'm trying to do with this balloon, this is a short CRE, so it's a 3 centimeter balloon, and you can do it. We say it's short because it's over a short wire. The traditional CRE is 5.5 centimeters, and there's a little bit of contrast in here. Go ahead and go to 10, and we're going to take this up to 10. I was aware of the fact that there were no stones in the distal bile duct, and so sometimes if there are stones in the distal bile duct, I'll try to push I'll partially inflate the balloon and then push those distal stones up the upstream duct and then try to push them away so that you're not trying to dilate between or up against the bile duct with the stone present there, if that makes sense.
Yeah, absolutely. That's it. When you have that happen, that's an absolute headache to try and deal with a stone that you've pressed into the wall of the bile duct. And it'll add some time to your case. So, you know, that's a good point. You want to be mindful of that.
I didn't see any waste here. I paused at 50% to 10 millimeter and didn't find a waste, but I'm going to pause here because I'm looking at the upstream duct and seeing if the stones are smaller than what I'm seeing on the dilating balloon. And it seems like, I don't know, it seems like you can certainly go a little higher and make their job easier.
Yeah.
But it seems like they would all come out with this.
Yeah, I think, you know, I don't think you have to go much more than about 10 or 11.
Okay, let's go to 11 then. Panel, what do you think? Respect to the question that Dr. Easler asked and also about how high to go on the balloon.
Generally, I try not to dilate more than the width of the distal part of the duct. So the more proximal duct is a little more dilated, maybe at 15 like you mentioned, but the distal duct's a little more narrow. So I probably wouldn't go much beyond what you're doing here.
Sorry, you wouldn't go much beyond what?
I was just saying, when I do balloon sphincteroplasty, I try to dilate to the maximal width of the distal part of the bile duct, and the distal part seemed a little more narrow than the wider part in the common hepatic.
Okay, so I'm going to take a picture of this balloon. That's an excellent point, and I appreciate you bringing that up because I forgot to mention that. So this is I'm going to go to a reference image, and now I'm going to scroll. Let's see. And what I'll do.
Yeah, there you go.
Oh, that's the last one. Okay. So I want to see, like, oh, you can't see the reference image that I have, but I think that's about the size of the balloon that I currently have
Yes.
at lower duct.
Yes.
So Jeff, do you agree we should
Wouldn't go,
stop at 11?
wouldn't go more than that. Would not go.
Wouldn't go more than 11?
Yeah. I agree.
Is the panel okay with that too?
Yeah, I
Yep.
think that's good.
Okay, so we'll do this, and then we're gonna use that 9 to 12 extraction balloon. Okay, so we're gonna, I don't know if you have time for us to see any stones. If you wanna go to another room, I'll take all these stones out, and then you guys can come back to see the clangogram or something.
Raj, we'll stick with you.
Oh, you wanna stick with me? Okay, all right. Then what we'll do is perhaps we could discuss a strategy for these multiple stones.
So,
And should we, I'm gonna play Urban Arnello here, but should we put the balloon up to the bifurcation and drag down all the way? Or where should we begin? And any teaching points that the panel would like to make regarding that?
I think if you started the common hepatic, we would end up with a great demonstration of using the emergency lithotripter basket. I think we would likely get the stone impacted at the bottom, so starting distally is probably safer.
Hey, Raj, can I ask you a
Yes.
few questions from the audience?
Yeah.
So we have a question with regards to cannulation. At what point do you give the wire away? Does the nurse give the wire away? Are you always starting with the wire? What's your approach to nurse assistant versus physician assisted cannulation?
Gonna go to 9 here. So I'm at 9 millimeter. I did hear the question, Sachin. I'm gonna answer that. I just want to make a point that the 9 millimeter balloon is what's inflated now. And when Carrie did the 9 millimeter balloon, I don't know if you saw her hands on that, but did you go all the way up to 12? She goes all the way up to 12 and then back to 9. But sometimes we have a technique, if the duct isn't too dilated, we'll do what's called a gentle 9, where it's just a little bit of a little bit of air in without going all the way to 12. I especially do that in the pancreatic duct. And so the 9 millimeter balloon is up now, and I'm going to inject some contrast here. And the reason I'm going to do just a touch of contrast is to size up the stone. There we go. Get a nice picture. I'm going to get a picture of that. Stop there. I'm going to send that over to reference, because what I want to avoid is I want to avoid like what, I'm sorry if that was Natalie or Vonnie, but the idea is that you want to try to avoid impaction of the stones distally, balloon down. And so you're going to try to split the stone. And as we split the stones, balloon down, that is. So I'm going to use my reference image, try not to take too much off. Go to 9 here. It reminds me of, oh, there we go. Did you see that endo image? Oh, nice. All right.
Carrie, I want to see that passion.
Sometimes you didn't hear me.
So the maneuver, that's one stone. So the maneuver to remove the stones, other than, inadequate balloon dilation, is I'm going to unlock the dials here. And what you're trying to get is the duodenoscope tip to be parallel to the bile duct. I don't normally do this completely under fluoro, but I think it's a good point to just show for a moment, is that I'm going to bring the, oh, is your balloon down already? Oh, okay. Well, let me show you here in a second. So we'll go to here, we'll go to 9 here. I didn't forget the cannulation question, but I just wanted to show this. So we're at 9, and it may not get much, but the maneuver is going to be unlocking your dials. You want the tip of the duodenoscope to be parallel to the bile duct axis. And the best way to do that, and do you notice on this fluoro view about the posterior part of the duodenoscope, so that the dorsal part of the duodenoscope is right up against the duodenal wall. If you look away, you are digging into that duodenal wall. You don't want to look away and do this maneuver. You want to get closer with the big wheel. Your balloon is up, or balloon's up, and it's going to be a gentle push and clockwise rotate, which will then get the bile duct or the duodenoscope tip distal or parallel to the bile duct axis. Everyone down.
yep, it straightens out the axis of delivery.
Straight. So as far as, and we're just going to try to get multiple stones here. So you go to 9, meaning splitting the stones, not trying to get too many stones at one time.
Now, Raj, is there any difference in your technique for when you're trying to capture small stones that might float up the duct? Any considerations there whenever you're doing your stone extraction maneuvers?
Yeah, sometimes you can't, did you hear the question okay? Go to 9.
Can you repeat the
Hello?
question?
Oh, the question was, go to 9 here. Oh, you got it. The question was related to small stones in a markedly dilated duct. And sometimes those are harder to come out. You're at 9 though. Those are harder to bring out. So sometimes you have to use a basket, or it might actually increase the balloon dilation even more. To try to get those smaller stones out.
Yep. A lot of times
Give a
I'll
little bit of
also
a
try and,
contrast
if you got a decent sized sphincterotomy and outlet, try and tap suction and utilize suction to, and
That's good.
transmit
Okay.
negative
Good.
pressure into the bile duct to pull those stones down below the
12.
tip of the balloon.
And this dilated portion, I'm going to go up to 12. I don't usually pass a 12 millimeter balloon across a fresh sphincterotomy. It's not so much perforation, but just immediate bleeding is more. And I don't like dealing with bleeding, but even though it's non-significant most of the time. But I have a 9. I'm going to go down to 9 now. But the reason I went to 12 initially is to try to get the bile duct sort of away from, or to sort of encompass the entire lumen of the bile duct to drag the stone down. So now we're going to go to 9 and then do the same maneuver. And we got another stone there. Okay, balloon down. And as far as cannulation technique, I tend to try to engage our nurses and techs more as much as possible. And I also think it's helpful because every once in a while, you really need, go to 9 here, where you have a difficult position and the tome is in a funny position, the duodenoscope's funny position, and you really need to rely on your nurse and expertise to maneuver a wire, manipulate a wire where you want it to go. So I tend to begin cannulation with the assistant doing the probing of the wire, and then after maybe a couple minutes or so, if it looks difficult or if I anticipate it's going to be very difficult, then I'll do physician assisted thereafter.
Another
Raj,
question.
I think the dilation did help you
Go to
here. You
12
got
here.
quite a stone burden, and I think it is speeding up the process in terms of delivering the stones.
Yeah, I think sphincterotomy alone might have been a little frustrating. Now this might be I have too many stones. I can almost feel too much resistance. Okay, balloon down. There's too much resistance, so I don't force it. I'm going to put the balloon down. In fact, I'm going to reassess, inject some contrast here. Sachin, how are we doing on time? I can talk slower or faster.
No. You're doing great, Raj. We have about 10 more
Okay.
minutes with you, and then we're going to break before we come back to a lecture and live cases.
Okay, go to 9.
So, Raj, there was another question from the audience.
Oh, the other thing about communication I want to bring up is that it's important that we do this, what do you call that communication? Closed loop communication. We do it all the time. I forgot what we called it. Don't laugh, Sachin. I know what it is. I just forgot what we called it. So closed loop communication. And so when I say go to 9, then the assistant Carrie will say 9. That way I know that I went to 9. So I think that's really helpful. They use it in the OR all the time. We use it in the interventional suite all the time as well. In luminal side, when we're taking polyps out, go to 9. You close a snare, they say close. You say 9. It keeps everybody on the same page. And sorry, Sachin, you had another question?
I do. Again, from the audience, why did you choose not to do a complete sphincterotomy in this case?
Not to do a complete sphincterotomy?
Yes.
Oh, well, I think the idea would be from a standpoint, it's a little bit of opinion, I think, because I don't believe that there's any good data to suggest that you can only do a partial. I've been to meetings like this and people, experts will tell me that they do a max sphincterotomy and then balloon dilate. I just, I kind of am like, why tempt fate? And so I tend to cut about halfway up or a little more. Go ahead and go to 9 or 10 here. And then also if they're younger patients, which this is, how old is she? Sorry. Okay, that's very young. But I would say that I tend to be a little more judicious in my extent of sphincterotomy. Younger patients, I tend to do a little bit more and do a complete sphincterotomy. to try to reduce the risk of sphincterotomy restenosis. Go to 9 here. I don't know if that makes sense, but I don't know what, I'd be very happy or very interested to hear other people's opinion regarding that. Going down.
Well, since I think you were
As
gonna,
far as complete sphincterotomy versus
yeah,
that
since you were
versus-
gonna do a DACE here, I don't think you need to do a maximal sphincterotomy. I think you can do a 5, 6, or 8 millimeter sphincterotomy, and then you're gonna dilate it up anyway, so.
I think.
I don't know if you, were you able to hear Jeff's comments? Go to 12.
Well, no, I was just going to continue this conversation about a complete versus incomplete sphincterotomy.
Oh, yeah, please.
For
Yeah,
this case, the reason why a complete sphincterotomy
nine.
was not done to allow enough sphincter space for us to perform a large papillary balloon dilation. If you look at the most recent ASGE guidelines for management of large stones, they recommend performance of a partial sphincterotomy with large papillary balloon dilation versus
12.
sphincterotomy alone. So that's really the explanation and the reasoning
have
behind
a
not
PD
cutting
bag in
all
there.
the way up to the junction between the sphincter and the duodenal wall.
Injecting here. So we're just doing, I'm trying to do intermittent fluoro here as we're doing the occlusion cholangiogram. You don't want to do too much injection, but enough to prove that there are no more stones left. Sometimes if we do mechanical lithotripsy, especially, or intraductal, we'll do sterile saline irrigation. But we don't really have to do mechanical lithotripsy. So I think we're okay and just, do you mind talking about that data? I know you're familiar with it, that sterile saline irrigation, go to 9. In patients who have multiple stones removed and.
I'm sorry, Raj,
Maybe
I
I
was
caught
on a call.
Stop
Can you
there.
tell me what the question is again?
Go to 9 here. The data on the sterile saline irrigation, for about 5 minutes. Sterile saline irrigation after stone removal, of multiple stone removal in a markedly dilated duct, and how it can reduce the risk of stone recurrence.
Yep, there is one single randomized control trial that's demonstrated continuous irrigation for a few minutes actually improves your rate of complete removal of stones. And I think we do that in routine practice, especially in patients who have massively dilated bile duct, and you can use normal saline. You can do it for a few minutes. You want to ensure that your extraction balloon is all the way up into the hilum, and then you start irrigating until you reach the distal end of the bile duct. That's been shown in a randomized control trial to reduce the amount of residual stones seen on subsequent ERCP.
Let's do a little irrigation. I think based on that, we're going to do a little sterile saline irrigation. Just a little, we'll be sure there's no small fragments. And then I think we'll be concluding the procedure, I believe. Going down.
Yeah. So Raj, a couple of other questions that have come up.
Go ahead and irrigate.
When would you consider performing SPY versus large papillary balloon dilation for management of large stones? At what point would you consider placement of a covered metallic stent for management of large stones?
SPY versus balloon dilation. I always consider balloon dilation first if it's feasible. If the stones are cuboidal or impacted, then I won't try to do balloon dilation, but irrigating here. But if the stones are smaller than the duct, no matter how big they are, I generally try balloon dilation. Stop there, go to 9. And then mechanical lithotripsy would be another option. SPY takes a little bit more time, and there's other costs associated with it. It's a disposable scope. You get the EHL out, the laser out, and several $1,000s later, you're doing that case. So I mean, it's not like those CRE balloons are cheap either, but I just think they're more expeditious and faster. And what was the other bit of the question?
When would you place a covered metallic stent?
Or 9. Oh, I'm so glad somebody asked that. I tell you, I think they're so overused, covered metal stents for difficult biliary stones. I think that I don't routinely do that, balloon down. I do think that if there's a difficult stricture downstream and you're trying to treat the stricture, it might be a strategy, but I wouldn't look at it as a sole strategy. And I would say that if you're, I would say that what I mean by soul strategy is we had data looking at our extrahepatic bile duct stone clearance rate. Is Sam on the panel? No.
Of course
he's
he
in the
is.
room.
Isn't he?
He's on the
in one of
panel and
rooms
moderating?
with you?
Oh, he's in one of the rooms. Okay.
Yeah.
Well, we looked at our data here at the university over 11, 12 years, and we had like a 99% stone clearance rate of extrahepatic duct stone. And a third of the patients required some degree of cholangioscopy. And understanding that this is a group of patients that are referred to us for difficult stones often. So we only looked at difficult stones. And what we ended up saying is that, look, you can't always do a single modality. Many times, about another third of patients, you have to do multimodality intervention with balloon dilation, mechanical lithotripsy, cholangioscopy, DHL, laser. So you have to have all that armamentarium at hand and have experience in it to adequately treat. But I would say that if the covered metal stent is the only strategy, I don't think it's a good strategy. But if it's going to then ease your treatment, resolve a stricture, or you're prepared to then do cholangioscopy at the next procedure after that, then it's fine. But a double pigtail stent or a straight stent would work too. Jeff, I'd love to hear your
Yeah.
comments about that.
Yeah, I think, can you all hear me on the panel?
Yes.
Yep.
Yeah, I think it really comes down to what the outlet looks like compared to the stone. So I think if you have a distal stricture and the stones seem like they're certainly bigger than the outlet, that's a situation where you'll probably want to use SPY and lithotripsy to break those apart and hold that out through the outlet. I really
What
haven't,
about the covered stent thing?
I haven't really used the cover stent much at all in the absence of a stricture. I think between DACE, SPY, EHL, even for very large stones, you should be able to, I'm oftentimes able to clear the duct. If there is a benign stricture, a bile duct stricture, that's probably where I would use a cover stent. But I think that's a separate, discrete pathology that you're treating with the stent. I wouldn't use a cover stent just to take care of stones. We'll be interested to hear from the folks on the panel if that is something that they utilize frequently.
Yeah, I agree with
Okay,
you.
we need to come out of the room because we got to turn this room over.
Perfect. Thank you so
And
much, Raj.
but
That
we're
was really
happy
nice.
to answer more
Thank you.
questions, though. We're just going to move aside here. to
All
allow
right,
them
we're
to
going
turn
to
over the
break
room.
for 20 minutes. We're going to be back at 2:50 p.m. See you
I
soon.
spoke to the debate helped you a lot. I think the speed to just
Yeah, exactly. That's right.
You are. Yeah. You should, like, at all. Maybe they're just so disappointed you didn't have endo rotors. Yeah. I think it came out pretty well.